Ladies and gentlemen, thank you so much for inviting me. You've been very kind. Thank you very much, Robert Jan Voorjaarscongres, for taking me out for dinner last night. I managed to get to the Vermeer exhibition. There are, if you know where to go, you can actually get tickets. But you have to be there before 1 o'clock and queue up underneath the museum somewhere. I haven't been to Holland many times. I think it's the third time over about 30 years. But coming here and seeing your Queen suddenly sparked off something in my memory, you know, a sort of family thing. And my father was in a detachment of Irish Guards that went in 1940 to escort Queen Wilhelmina off Holland to the UK. And the whole detachment was sort of killed or capped. My father managed to escape by swimming out to sea and got on a boat. He was a very good swimmer. But he was later reformed in his regiment, sent out to fight a rearguard at Dunkirk, and spent the rest of the war as a prisoner of war in Poland, then Germany, and was released by the Russian Red Army. But it's funny how these things, I'd completely forgotten all about it. Was sort of sparked off coming and actually seeing your Queen, these sort of memories, and you sort of suddenly think, well, you know, maybe I lived with a father who had PTSD. But going back to be how grateful I am, this area of research I'm going to talk about today, I worried it was sort of dead and gone, actually. And I'm really pleased to be able to talk about it because I'm going to talk about 5 studies. So I'm emeritus professor now. And I retired in 2016, and so the last study was published in 2018. And you think, don't you? You know, you think, well, looking back on my research, maybe this is one of the better things I did. And you think, well, somebody else will do this, but I'm not aware of anybody else. I look, you know, occasionally in PubMed and see if anybody's looking at symptoms of psychosis and violence, but I can't actually find that. And the whole thing about this is it's about symptoms. This is not studies of diagnosis. Yeah, sure, I'm really mainly interested in schizophrenia and violence, but one of the things to take away today is the whole notion that this is about symptoms. It's not about slapping a label on someone. And think about it. Think about schizophrenia. And think about other studies which are probably more dominant now in the literature than mine, which are based on primarily administrative case registers and using a diagnosis. And the essence, which all forensic psychiatrists and most adult general psychiatrists know about when you assess somebody, certainly for a court assessment, is were the symptoms present? There's no defense at law if the patient was abusing drugs at the time. Or they had a diagnosis of schizophrenia 5 years earlier but haven't got the symptoms now. You have to demonstrate that and convince the court. And that is the key, I think, to what we were doing in terms of our research, my research group at the time. So, this particular paper, this takes me way back. I'd recently been appointed as a professor. And I go to see a representation from the best project probably ever done, actually. Certainly the most expensive, $7 million. The MacArthur, mainly people call it the risk study often. And this particular paper was published in American Journal of Psychiatry, so it must be true, in 2000. I'm sitting hearing the sort of preliminary results. And what this paper says is that there's no association between delusions and violence. It also says, in another part, that delusions do not predict violence. And if you understood the whole sort of drive behind the MacArthur study, it was all about risk prediction. So I'm not going to talk about risk prediction today. But it was clearly, you know, maybe the authors could make their fortune by developing a CD-ROM that could predict accurately those patients who are going to reoffend. And of course, that area of research, in my opinion, is dead and is going nowhere. And you cannot predict accurately. It's just too inaccurate. So I'm sitting there. So there's no associations between delusions and violence. Delusions do not predict violence, so there's no association. I'm thinking, why have I got a job? I'm a forensic psychiatrist. And this, I suppose, takes me back to a sort of golden early era of my training in which you believed that patients were becoming violent because they had symptoms. The symptoms were driving the violence. So what am I aiming here to do? So talk about a renaissance of research into psychosis. I think it's perhaps sort of fallen off in some ways, but psychotic symptoms particularly. The notion of a pathway, the importance of delusions and anger. I'm not going to talk very much about the implications of risk assessment, but also a bit about the implications for prevention and treatment. So during the sort of, from about 2000 onwards, there seemed to be sort of papers refuting what I think was just simple common clinical sense, basically. So there's the rise and fall of threat control override. That was a series of studies, and then it wasn't replicated. There were some colleagues who were looking at first episode studies during that period, mainly from the ESOP study and one or two others in the UK, showing no associations between symptoms in first episode psychosis and violence. There was very influential, and still some researchers do believe that there's nothing to do with psychopathology. It's all due to social factors and criminological factors. The Bonta et al. Review at that time, 98, was very, very influential. There's then Applebaum's paper, doesn't predict violence. And then there is Sina Fazel's work about the whole notion about violence is due to comorbid substance misuse. Now, if you think of somebody with schizophrenia, violence could be due to comorbid substance misuse. But I don't think you can actually show one way or the other using a case register, and certainly not if your outcome is criminal records. Criminal records are not a measure of violence. They are a measure of police and court activity. The overwhelming majority of violent incidents are never captured by criminal records. It's really important to understand that. No criminologist would entirely rely on criminal records for the last over 40 years, actually. It's only psychiatrists. There's then a period of re-evaluation. So there's the Swanson study, which is the Katie study, which was a trial of different medications for patients with schizophrenia. And this is reanalyzed. Richard Van Doorn did most of the analysis for this study. And that begins to find something different. That looks at individual symptoms using the PANS and finds that there's a relationship with persecutory ideation, that negative symptoms lower the risk, and there's been a subsequent meta-analysis which says that there's no relationship whatsoever with negative symptoms. But I really think that's another area, another method that doesn't work in looking at violence research in relation to mental illness. It doesn't work. Recycling old, poor quality studies will not provide you with any answers. And he found interactions, which was very interesting. So there's then, I think, a really interesting study, a meta-analysis, despite what I've just said about meta-analyses, but think about it. And this is a very simple approach. It is looking at homicide during the first episode period and then subsequent in the studies that actually showed that. And what it found was that it's sort of more than 15 times more common to have homicide during the first episode period than subsequently. So it's really important to think about the life course. Schizophrenia is not something which is constant in the majority of patients. For a third of patients, it goes away entirely. But then it comes and it goes. And that's really important. And that is not going to be captured by a label of schizophrenia somewhere in an administrative case register. You have to know whether the symptoms are present at the time. So there's then the reanalysis. Doesn't it make you mad, actually? I was talking to Richard Van Dorn. There's Elbogen and Johnson did this study from the NESARC survey data, big survey data from the USA, and they found, after putting lots and lots of adjustments in, one adjustment after the other, for criminological factors, social factors, there was no association with severe mental illness and violence. And that's published in JAMA Psychiatry, or I think it was Archives of General Psychiatry at that time, so it must be true. And he reanalyzes it, but he looks at the subset of data that shows whether the violence and the symptoms were around in the last 12 months. And actually, he does exactly the same again, and he actually finds there is some. And this is a relationship. And this is really important because it's all about temporal proximity and how close in time the symptoms are, or the diagnosis actually in this particular study, how close it was to the violence actually occurring. So I'm always sort of concerned about the sort of rival hypothesis to a lot of the work I've been doing, that the relationship between psychosis and violence is all explained by comorbid substance misuse, which it isn't. I think it may be true that people in Scandinavia, where the case register is based, have a higher risk of violence in relation in some way to substance misuse, but you don't know. You don't know whether symptoms of psychosis or other mental disorder was actually present. You know they might have had a diagnosis, but you don't know at the time. You don't even know if they were abusing substances. The data don't tell you that. It's not there. So you do various adjustments and you find this big, strong relationship. And where does that take you? Well, I'll tell you where that takes you. It starts getting around clinical services, and nurses start saying things like, well, do we have to have this patient? He's violent, doctor. And everybody knows that there's this important paper we've heard being published showing that it's all down to substance misuse. And we don't treat substance misuse on this ward, doctor, do we? Do you see where it goes? It's really important. So, as I say, systematic review meta-analysis, which concluded that it's all mediated. Although it didn't do any mediation analysis, you can't do a mediation analysis in a meta-analysis, as far as I'm aware. But it claims that it's mediated by substance misuse, and that's not true. So, let's reconsider the relationship. So there's violence when a patient with psychosis is acutely psychotic. There's violence that could be associated with social deterioration due to psychosis. But there's also violence which might be over most of the lifespan in many patients with schizophrenia, which is totally unrelated to symptoms of schizophrenia. And that's terribly, terribly important to think about and to carry out a study that can eliminate these problems. So I'm not talking about, certainly not talking about the second. I'm really interested in violence when acutely psychotic. So, new research post-MacArthur. So the key question, are delusions the key symptoms? If so, which delusions? Is the pathway direct or indirect? Is the association causal? Can't see, actually. There's a clock here, actually. I can't see what I've written. What did I say? I can't remember. What's the last one? Anyway. Oh, yes, what are the implications for treatment? That's right. Causal. Yes, that's that second to last one. Is the association causal? Now, causality. There is the thing. I've started, this is almost, if you send a paper to a psychology journal, it's usually a good one's usually the other side of the Atlantic. You can virtually hear the screams and shouts of anger by using the C word, causal, all the way across the Atlantic. I mean, you daren't say anything about cause. This talk is about causality, okay? You may say, when I've gone back to the UK, rubbish, nonsense. I believe this is all about trying to establish causality. So, this isn't really about causality. This is the first study. This is sort of saying, well, what's the key symptom? And this was a meta-analysis. And this meta-analysis actually is an individual subject data meta-analysis. So what we actually did, this was published in Schizophrenia Bulletin. And we have 7 surveys, and we're not putting together the final results. We're merging the individual subject data. So they're all going into one big data set. Because it just so happens, in these particular surveys, we've got the same outcome measure for each survey, and we've got the same or sometimes similar measures of psychopathology. And that actually is, if you're going to do meta-analyses, I believe that's the only meta-analysis to do if you want to look at violence and mental disorder. So what do we find? Okay, let's be honest, the PSQ, it's only a screening instrument. It's got 5 symptoms, and it tends to be used in the first phase of UK national surveys. And what we've done here is essentially, so the PSQ, 3 out of 5 is thought to be probable psychosis. But the key thing was to look at the 5 individual symptoms: hallucinations, thought insertion, paranoid ideation, strange experiences, hallucinations. And when you start adjusting for each other, it's really only the paranoid ideation which is associated with these different levels of severity and repetitiveness over a 5-year period of violence. So, is there an association beyond comorbidity? So, of course, all that could be confounded. It could be confounded by substance misuse. So, the key thing that we're finding is that there are some associations. So, the pale, the white bars are unadjusted, and the black bars are adjusted. So we're adjusting for these various other forms of psychopathology. There's also, it wouldn't fit on the slide, I'm afraid, there's also, next to depression, there's anxiety disorder, and there's drug misuse as well. And what you're finding is that if you look at associated, say, antisocial personality disorder with hypomania, yes, there's a strong association. But once you start adjusting, these things disappear in most cases. But in paranoid ideation, they continue. So even with drug misuse, which is sort of in between antisocial personality disorder and alcohol dependence on that bottom histogram, there is still a significant association. It still remains. So adjusting for these potential confounders does not take it away. The relationship still stands. But that, of course, is a cross-sectional survey. So let's look at something else. So there are 2 studies looking at direct and indirect pathways from delusions to violence. Okay, so the first one, this was published in JAMA Psychiatry, so it must be true. And this was back in 2013, I think. What this is a sample of over 400 first episode psychosis patients from East London. And that's the area I'm working in at the time. And that's the catchment area. So I'm a forensic psychiatrist, but I'm also doing research there. And we were greatly helped by Robin Murray, now Sir Robin Murray, and we copied the method used in the ESOP studies of that era. But we also, unlike theirs, we put in MacArthur risk instruments as well. So we have a lot of, I'm still a believer that you might, at that time, that you might be able to predict future violence by taking measures at the first episode point. Anyway, what we actually do here is carry out, I've been very rude about JAMA Psychiatry, haven't I? And you can tell I'm a bitter old man who's had many, many papers rejected and don't really like the peer review process very much. But this is one of the few. This is the only time in my academic career where this unknown reviewer changed my life, and all this research is dependent on one. So I talked about colleagues who've been looking at other first episode psychosis studies around the same time, and they can't find any association. So what you're actually looking at back, so that the patient comes and sees your researchers, who are 3 psychiatrists in East London, and they get every bit of information they can about any violence over the previous year and the symptoms over the previous year. So it is a bit retrospective, let's be honest about this. But we're using sort of really good instruments to get all this information. And we've got a bit of an association. I'm terribly excited, and I send it off, and it comes back, and they say, reanalyze it all again and do a mediation analysis. And I say, oh. And the next thing is, when I've sort of calmed down, I then say to, the other thing about this sort of research, this is the reason why nobody is, I think, it's very difficult to do. It's really difficult. And you need a team of people. You need people who can do things you can't do. So the next thing, I ask the question, what's a mediation analysis, I say, says the professor. Anyway, and they sort of give me a bit of a seminar and they explain it, and I still don't understand. But anyway, the statistician goes off, and I've got Simona Ulrich, who's a psychologist, and of course they're much better trained in research than any psychiatrist is. And they do this mediation analysis, and what they actually look for, on the suggestion of the reviewer, they're looking at, we just so happens that in this wodge of data, we have the MacArthur, a questionnaire that asks, how do you feel on the basis of your delusions? The Maudsley Assessment of Delusion Scale. And this says, did the delusion make you frightened? Did it make you depressed? Did it make you angry? And what we do is put this into a mediation analysis. And we also, meanwhile, we're looking at the individual, and we're adjusting for everything. We're adjusting for psychopathy and substance misuse and trait, you name it. It's amazing we found anything at all. We had so many adjustments in this. Anyway, we find that there are a number of delusions. So there are some direct pathways. A small number of delusions show a direct statistical association, but that's only for minor violence. What we're finding for more severe violence, and this fits in with the experience of a forensic psychiatrist, really, the sort of cases that most of my career I was assessing, is there's a limited number of delusions, although they're quite common delusions, being spied upon, persecution, and conspiracy, and they are mediated by being angry due to those delusions. So it's not just being deluded, but it's being angry on the basis of the delusion, leading to serious violence. So, here's an example. I have to be honest, I don't know. This is Mr. Cho. Mr. Cho shot to death 32 people. He had a Glock and a Walther. And there's various information, including his writings, and he sent it from Axe Cho, an axe relating to Little Axe with Bob Marley's song. If you're a psychiatrist, you know, of course, these are the writings and ramblings of somebody who's drifting into schizophrenia. He actually was briefly admitted and then discharged again. There's a story that you hear as a forensic psychiatrist. And he was able to buy the guns because of law in Virginia allows you, if you haven't been compulsory admitted, you can buy firearms, or you could then. And so he buys 2 handguns and a large number of hollow point bullets to put in the magazines and kills 32 people. But what he's actually saying is that you can see you vandalized my heart, raped my soul, tortured my conscience. He sounds pretty angry to me, and he sounds like he's being persecuted. Okay, so I would argue that he's an example of what I've just described. Right, revenge is sweet. We're coming for the MacArthur wonderful study. They put all the data. The data is actually on the internet. You can download it. And Simona Ulrich thought, well, what we need is another data set. And this data set's actually better than ours because they are seen at baseline. These are discharged patients from 3 psychiatric services in the USA. It's over 1,000, and they are seen every 10 weeks. So there's baseline and 5 follow-ups. So the interviewers are going round to them, or some have been readmitted, but most of them are back in the community. And they have the same instruments that we've used, by and large. So there are 2 things in this study we looked at. I said 2 things. I said that the original 2000 paper, Applebaum, said there's no association between delusions and violence, but it also said delusions don't predict violence, okay? And actually, when Simona Ulrich analyzed these data using a predictive method, she used a more up-to-date, better statistical method, it didn't find that there was any predictive possibilities at all. I'm going to explain this in a bit more detail if I've got time in a moment. What we did do was look at it differently and look at the association between the delusions during the similar time period and the violence. And then we found virtually the same. We found very similar delusions being spied upon, followed, plotted against, under external control, thought insertion as well. They had used the Maudsley Assessment of Delusion Scale, but they called it the MacArthur Maudsley Assessment of Delusion Scale. They bought it, essentially. And that mediated the anger at the delusional belief, serious violence in the same study. So it's almost a perfect replication of a totally different first episode psychosis data set. And the bus killer, he shot 4 people. So the bus killer, ever since in New York, ever since September, he feels he's being followed by people who are out to get him. Remember that from a couple of slides back. But on Friday morning, he decided he'd had enough, and today was going to be the last day that he was going to feel threatened. So, yes, well, that's all you need to know, isn't it, really? It's like a sort of forensic case, but fortunately in Holland and the UK, it's difficult to get your hand on a automatic pistol. So, role of treatment, study 4. So, we happen to have another data set, and this is published in American Journal of Psychiatry. Robert Kears, late Robert Kears, sadly, was my postdoctoral student at that time. And what we've got here is a large number of prisoners who are released from prisons all over the UK. And we follow up 56% of them. Now, to many people that might not sound very good, but to actually get 56% of UK released prisoners is quite remarkable. We actually hired a private company to do this for us. And what we also, so they get an interview in the prison, a clinical interview. They're seen, we have a large number of psychologists who are trained to make diagnoses using clinical instruments, and they're followed up by lay people. We use that self-report instrument that I described a moment ago, the PSQ. So what we found, you can see this. One other thing to say about this data set. This data set was hanging around for 10 years. And I was so disappointed. And what I actually did was I asked a statistician, I said, look, the prisoners with schizophrenia, they must be more likely to reoffend. And I was so disappointed that there was no significant difference in terms of violent reoffending amongst released prisoners with schizophrenia and the rest. But then 10 years later, you suddenly have a brainwave, something clicks off in your mind. You think, hang on, I wonder if they got treated. And what we found, I know the numbers aren't large, but if you look, if they had continuous treatment during imprisonment and after imprisonment, there's no significant difference. And that's after all the adjustments and everything. If they had, what surprised me is actually, even if they had any treatment at all for the psychosis. We also looked if they'd had treatment for drug misuse. That had no impact at all. But if they'd had any treatment for psychosis, even though they didn't get it after they were released, that seemed to have some effect. But for those who had no treatment at all, and of course the prison authorities were probably totally unaware, only the psychologists who interviewed these people, and part of the consent to be in the study was not to tell the prison that you've got schizophrenia. Only they are actually aware. So that was sort of really quite striking in terms of the effect. And we also looked at it it was sort of mediated by paranoid delusions. So it was, the other symptoms we also controlled for whether it was strange thoughts in your mind. It was definitely the paranoid ideation coming back again that really mattered. So, one more study. Can you do something? Can you all put your hand out like that? Everybody, put your hand out like that. You've got to do it. I'm your guest. You've got to do what I ask. Right. Do that. Thank you. You can put your hand down now. Now you're going to remember this forever. This is a new finding. Actually, I got this off somebody else. There's a study by Candice Odgers in 2009 in the American Journal of Psychiatry. And what they do, I've never seen another piece of research, never replicated, never taken any further. They saw a number of, and they were looking at depression as well. So anyway, that's another story about depression and violence. But they were looking at people coming into emergency rooms in the USA, and what they did was follow them up at sort of weekly intervals and looked at the fluctuation of symptoms, okay? And the key thing, it wasn't so much the symptoms. It wasn't being present. That was certainly very important. But it was the fact that the symptoms were fluctuating. The fluctuation of the mental state itself was directly related to the violence. And I would say that isn't a causal association. Yeah, I'm not entirely convinced that depression drives violence, but that's me, that's my problem. But whatever it was, whether there were some psychotic symptoms hidden in there, because they only used one instrument, I don't know. But the mental state fluctuation, remember that, the mental state fluctuation was itself a driver. I find that very exciting, actually. So, what we did, this was our last study published in 2018, and we were looking at positive and symptom. This was yet another data set. These were patients released from medium secure services. So it's somewhere between a maximum secure hospital. So there are forensic psychiatrists who work in these services in the UK. And I had patients in medium security. So there's over 400. And we're looking, in this, to be honest, we haven't got all these fluctuations. We've only got two. because we sort of measure them at baseline, at 6 months, and at 1 year. So what we're finding is that, again, it's being mediated by anger. We haven't got the Maudsley assessment of delusions, but there's anger in the PANS, and we're finding that it's suspiciousness and persecution is the one and only leading key symptom. It's being mediated by angry affect. And we even check it to see if it's the other way around. We check and see if it's actually the delusion that's mediating the link with anger. No, it's not. But what we also do is don't worry too much about this. It's too small to see. And even, actually it's in the paper. I checked last night. Obviously missed in the proofs. The arrows don't go the right way. Obviously an arrow going up is going to be increased. But basically what it's showing is, in a whole series of analysis, we're showing, as you'd expect, an association between positive symptoms of psychosis. So most of these patients have got schizophrenia or schizoaffective disorder. They've committed mainly violent offences, and we're measuring whether they've been violent again. And there's an association, a negative association with negative symptoms, and a positive association with increases. But we also are looking at this sort of fluctuation. It's in the paper. It's a complex piece of analysis. And so actually having a fluctuation, a change, a shift, as well as having an association with positive symptoms, a shift in positive symptoms, even if it's getting lower, can actually be associated, just the shift itself. Okay. So, how long have I got? As soon as possible. Get off the hook. All right. So, yeah, I am coming to the end now. So, do never confuse prediction with causation, because a lot of people do. Just the fact that you think you've got something that predicts doesn't mean it causes it. This is, I haven't got time to go into this in any detail, but this is, you've got to remember that there is an alternative. Besides things like the HCLR20 and measures that people use, there is another way of thinking about it. This is the FBI, think about threat assessment, looking at pathways. And so the sort of model I've been talking about, the association, fits this much better. Yes, it's much more truncated in most cases of acute psychosis, but there are, the grievance, of course, is the paranoid beliefs, the violent ideation, and the research and planning of the attack can be momentary, but it's the same sort of model. Just one last thing. I'm not going to have time to do this in great detail either, but this is trying to get you to understand. This was about method. Simona Ulrich prepared these two slides for me. This slide is showing you individual cases and looking over the different periods of measurement from T0 to T5, whether there were delusions present. And we're interested in case 97, bottom right-hand corner. This particular case didn't have any delusions during time 0, but did have delusions at time 1. So, this, sadly, you need some time, really, to this slide. What it's actually showing is, she told me I wasn't told, this temporal ordering. I always call this the predictive model. This is what everybody does. Does some measure at time 0 predict something happening like violence or suicide, whatever it is, at time 1? Or it could be time 2, or it could be time 3, okay? And that's what everybody does. But actually, that will miss the most important thing. What you need to see, you need temporal proximity, not predicting something, because if you look, at time 0, there was no delusion present, but actually if you look, the patient is violent at the next measurement. Oh dear, there's a negative statistical association. Oh dear, it's all wrong, because you're predicting it. But if you look, for example, in what so that was her first model she used when she reanalyzed all the data. When she did it our way, we get a significant association because at the same time you have the delusion. So the delusion is present. You know it's present. It's been measured. And the violence was present as well. And that, if you can understand that, this took, by the way, you're having about sort of 15, 20, it just took me 10 years to understand this. Simone Ulrich used to sit me down and go over it and over it and over it. And I said, can you just show me that diagram again, Simone? Anyway, so some of you might have understand this who are much better researchers than I am. And so future research, I haven't got time to do that now, but clearly there are other symptoms. We happen to find delusions are the most important. There are other syndromes. Many of the cases we're looking at with severe violence, they're often more intact in terms of their illness. Not like often the sort of patients that you see which aren't in forensic services are much more severely affected. And I think the syndromes are different, and there may be different findings there. One last thing, treatment. It may be, this makes me think of Jim Van Os actually, and the importance of affect, that it may be that it's not so important to treat the delusion, but if you could treat the angry affect, that might be the key thing. Thank you very much.
Thank you very much. Thank you, Professor Coid, for your insights in the importance of the paranoid symptoms. And I also interested by your insights in other things like the journals and the review process and how you can ask the audience to do all kind of tasks. So interesting. But this is an interesting topic, and important is to know that Professor Coid will also have a meet the expert session this afternoon. He will be interviewed by Koen Verbraak. And we have also Regina Schipper, our colleague who was involved in the treatment of Michael P. in Den Dolder, who committed a serious crime. And he will also discuss the experiences as a psychiatrist if you are having those patients. And there's also the patient perspective with an ex-forensic patient that is involved in the discussion. And the session will be held in Auditorium 2. So if you're interested in this topic, please come for this interesting discussion.